about the group of patients. Now, do you mind just to just tell us a little about your background and how you came to Crookston?
Sure. My name is Fashoro. I'm a board certified internist. Um, I did my initial residency in the United Kingdom in England, and then came here to New York City and completed a 3-year residency and did my boards, certified initially and recertified again in 2016. I've been in Crookston, Minnesota since 2007, so about 12 years now.
Yeah.
And I've covered spine patients for the past 10 years. The journey has been a very good one, seeing the transition from performing the open surgeries, the old-fashioned open surgeries. In my anecdotal experience, what we have noticed is, dating back even 6 years ago, when the majority of the patients were open, the average length of stay for these patients was between 5 and 10 days. Majority would leave about the 5-day mark, but it wasn't unusual to have patients that stayed up to 10 days. And it was standard that, about 80% of these patients would have ileus, just because of the nature of the surgery and the narcotics. And, the pain was also more, so they required more narcotics.
Can you describe to us, I apologize interrupting you, but for many of the people that are not familiar with these terms, can you describe one of the cases that you take care of a patient after surgery with the ileus? How would it express itself? What complication would come out of it? Can you explain it to us?
So most of these patients, typically the second or third day after surgery would have abdominal distension, bloating, and some discomfort. And typically they're not able to pass gas, or if at all, they pass only a small amount of gas. But usually they're not able to pass stool, they're not able to defecate. That's usually the first sign, because we ask patients if they're able to go to the bathroom, and typically they say they're unable to. And then we probe further and do x-rays, which confirm this condition called ileus. In some layman terms, they call it lazy gut, or your gut is just not moving the way it should. But it's a little more complicated than that in spine patients because of the nature of the surgery, and also because of the pain medications. So fast forward, what I found is this is the commonest reason for patients staying in hospital longer than they need to. And we would use medications to try and take care of that condition, which would add another 3 to 4 days onto the period of hospitalization.
What is the kind of worst form of ileus? What can it lead to if you don't treat it acutely, aggressively right away?
We've had a few cases where, the ileus progressed and the patient either vomited and the vomiters went into their lungs and caused something called aspiration pneumonia, or in some cases, actually the bowel, believe it or not, can perforate and require surgery.
Yeah, this is a dangerous situation.
It is very dangerous.
Yes, please. But because of the open surgery require more pain medication, those pain medication put more bowel to the sleep, so the risk of ileus is significantly higher.
Much higher, much higher. Now, fast forward, the last 5 years or so since we started doing or following more cases of olive patients, the patients that had the minimally invasive technique. The first striking thing from an internist standpoint was the decreased length of stay. That was number one. But from a patient standpoint, the pain was a lot less, which is really a big deal because that led to using less narcotics, getting home quicker, and also, the time to healing and the whole patient experience. The time to healing was, from time of surgery to healing is significantly decreased. But the overall patient experience was very positive because it now became a more comfortable surgery. And we anecdotally noticed that most patients now leave the hospital 48 to 72 hours. Very rarely do I see the 72-hour patients this day and age with the olive, which is remarkable.
As a matter of fact, I did 4 surgeries last time. All the olive went home within 24 hours. The thoracic one, we kept 1 more day, but generally, I think, your experience as well reflects our statistic that 96% of our patients are ambulating within the first 24 hours. And that's important because we have as well a statistic from open surgery that only 5% of the people after open spine surgery ambulate within the first 48 hours. That explains why those added days are there, add to that. But, if they can ambulate, obviously, not only it's important that then they can do physical therapy, progress faster, they can go home, but as well, coming back to Elias, if you're upright and moving, the gravity is your friend and helps you with the intestinal system to come back to life. But you and I, we have worked together for last 8 years or 7 years.
Yes.
And when I started as well, I did lots of open surgery, and obviously we compared my open surgery to my minimal invasive surgery. But what would you say? When you see the patient first post-op visit, open versus minimal invasive. Now, what are the difference in the presentation of the patient?
Pain. Yeah. I say 3 times because that's the most striking thing. The pain control and the pain the patient is experiencing. Pardon me here. I'm not sure what happened here.
We still hear you.
Okay. Yes. The pain control is significantly improved when you look at olive versus open. A lot of the patients, typically on post-op day number 1, rate their pain between a 2 and a 4. And usually most of the patients are already asking to be discharged. The reason why we keep them another 48 hours, another 24 hours, is usually because we're being extra cautious. We want to make sure they've been cleared by physical therapy. We want to make sure that everything is okay because in our minds, it's too good to be true. And we'd rather err on the side of caution, keep them 1 more day just to make sure we have, all the ducks in a row before we send them home. Yeah. But truth be told, for instance, this morning and yesterday morning, I discharged patients that were just 24 hours post-olive. Yeah. Because they had pressing issues and they wanted to go home. Yeah. It's been an amazing patient experience. And from our standpoint, I remember my radar used to be look for ileus, look for perforation, look for aspiration pneumonia. Honestly, I haven't seen a single case in the past 4 years.
Yeah.
Not
Well,
a single case of those serious complications. Not from the olive.
yeah, and considering, I just we came from the university and we discussed there is a case scheduled for a 1-level regular surgery for 7 hours, whereas we do that under 1 hour. Considering that every 30 minutes in the surgery adds 17% to the combined risk of the surgery, you just described from your experience those complications that we for a long time we know is associated. Just even the longer surgery itself, not even the additional damage that the open surgery does to the tissue. And I think as well, you and I, we have worked on together for so many years, and we understand that what we are doing in that small place is something very unique. Now, again, we are in a hospital in that there's a critical access hospital. We are providing a care that the people in the big city, in the university, would need to have a 7 times longer surgery with added complication and so on. But as well, we know that what that means for the overall care of the patient, returning faster to their life. I just had a patient, I put a testimonial out there. 10 days after the surgery, he walked his daughter down the aisle. He would be possibly still in the hospital after open surgery.
Yes.
And this is truly...
That's amazing. That's amazing.
And, as well, we are lucky to be in a hospital that is very efficient, but some of the hospitals, every day in the hospital is somewhere between $3,000 and $5,000. And our paper that we published shows as well that it's at a $3 billion with a B healthcare saving to US economy if all open surgery could be done minimally invasive with the olive technique. So I think
minimally invasive.
Yeah, you and I, you're in the right place to provide that care, and I'm so thankful for your help, because without your help, none of the things I do would be even remotely possible. And you have been such a great partner to us. Now, I understand this has been a path, and we have medicine is generally we are conservative for a good reason. I'm sure you know the history of Barry Marshall that said, don't cut people's stomach out, just give them antibiotic for gastric ulcer. And he had to fight 30 years of battle. And you and I, we know lots of people were damaged, died, they mutilated, because it took us 30 years to accept that change of concept. And in a way, I feel that way. Now, I go and give these talks a lot, and I tell my colleagues, come and look at the data. If you would go out, how would you describe, how would you encourage our peers, doctors and so on, to just start looking into that? What would be your message for the rest of the medical world?
Well, for one thing, outcomes are better in my experience, because I also see these patients postoperatively when they come to clinic, on an elective basis. So in my mind, I think they say the best testimony is, what you would want for your family members. If my family members were to, or one of my family members was to need any form of spine surgery, undoubtedly based on my experience in terms of, number one, decreased length of stay, number two, reduced complication rate across the board. And when I say across the board, I mean complications that are unique to spine surgery and complications of any kind of surgery, from any kind of surgery. So across the board, the complication rates are at least 70 to 80% reduced in my personal experience. Now, beyond that, seeing them electively in clinic, we noticed that the time to recovery, time to getting back to work, time to getting back to your prior level of functioning is significantly decreased. And the patient satisfaction scores are very high. Your hospital metrics are better because your length of stay is significantly reduced. That's very important from an internal hospitalist world, your length of stay is a big deal because, it number one shows that the patients are recovering quicker. Plus, there's a huge financial benefit to it for facilities. This is a significant reduction in length of stay, 48 hours compared to 5 to 10 days. I'm not an economic expert, but if you do the math, I'm sure it translates into a significant amount in terms of dollars and cents. So,
our first paper was, for the last 30 years, every innovation in spine has made it more expensive. For the first time, this innovation made it actually cheaper. Our first paper was an economic study and showed that we are saving $3 billion from US health economy by converting to this kind of surgery if everybody would be on board. But now, I'm so thankful that, that you have a good partner in you.
Thank you.
Yeah, and I think that is the highest reward any surgeon can get if somebody of your caliber says, if my family needs that, this is what they are going to get. And I think that is, I cannot think of any better compliment than that, because I think you and I, we know that medicine is a very personal field. We are invested in our patients.
Yes.
Our patients are, they're in a way our extended family. And I think that is why I'm so eager about getting the word out. It's not enough that we do that. I think something majorly needs to happen. And so I'm so thankful that you have been our good partner in this.
Thank you very much.
Well,
I really appreciate it. It's my pleasure.
Thank you. Mike, do you have any other question for Dr. Fashoro?
I actually had like 7 questions and you covered every single one of them. I think the big thing is, you asked it from a provider perspective, but one of my questions was, for people out there wondering about, the OLIF procedure, and if they're wavering between OLIF and TLIF, what would you tell them? It's probably the same thing that you would tell your provider, but again, that's important for patients to understand too, that, it's quicker time back to walking, it's quicker time back to work, it's less hospital time, all the different things that you mentioned. I think it's important for everybody to understand. And
we have done probably closer to 600 OLIF just in Crookston. So this is Dr. Fashoro, don't be humble. Your data is based on a vast number of the patient by any standard. Anybody who has taken care of that many patients is authority on that. And so you're an authority on taking care of this patient. So I would rate your experience there way more than anecdotal. Anecdotal is if you take care of 20 patients or 10 patients, but you have been taking care of hundreds and hundreds of these patients. So, but you're just the way you are, a humble provider.
In total, I've probably taken care of about 2,500 spine patients over the past, at least 2,500 over the past 10 years.
So your experience by no means is anecdotal. This is a vast number that, by any standard, that would be a landmark study. So I thank you again so much, okay?
Not a problem. Not a problem. My pleasure. My pleasure.
Bye-bye.
Thank you, Dr. Fashoro. Take care.
Take care. Bye-bye now.